Hello, dear friends, supporters of psychedelic research, ladies and gentlemen. My name is Jiri Horacek. I work in Klecany, Czech Republic, at the National Institute of Mental Health and Charles University, Third Faculty of Medicine. But today I'll talk on behalf of CIRES, a psychedelic research foundation, which we developed specifically to support the psychedelic research in Czech Republic and also in the other countries of the Central and Eastern Europe. I entitled my talk as Psilocybin and Ketamine in the treatment of major depression and the existential distress in the palliative care. So today I'll focus on two subjects, depression or major depression, and the existential distress, which is quite typical in patients suffering from the oncological disorders, typically in advanced stages. And I also talk about our studies, which plan to compare the psilocybin and ketamine, two candidate drugs, both sharing the psychedelic effect or psychedelic properties. And both of them are the candidate drugs for the fast antidepressant effect, both in depression and existential distress. To support our research, we brought the CIRES, the Psychedelic Research Foundation, which is focused to support research at our institute and also other projects. The question is, what's our credit or how we are credited? So first, we are somehow credited by the tradition because our institute was quite famous in 60s when we began here, or our older colleagues began here with the psychedelic research, typically with LSD. And also at our institute during that time used to work Stan Grof, one of the famous person in the field of psychedelics. I think that we are also credited by the current situation because from 90s we run the basic and the clinical research of the effect of psychedelic drugs. So we have a lot of experiments on rats and also on humans with different psychedelic drugs. We are fully equipped, and you can see here our lab when our research is conducted. Typically, this is the Faraday cage. So the EEG experiments are done here. Here is our 3 Tesla magnetic resonance for the magnetic resonance imaging of people who are intoxicated by psilocybin, ketamine, and other drugs. And here you can see our modern institute oriented on the neurobiology and research in this field in general. Our credit
Hi,
also stands
Jiri, I'm sorry to interrupt you. Are you trying to share your screen? We're not seeing.
You cannot see my screen?
No, you need to press share screen.
Aha, yes, okay.
Thank you.
Thanks. It's better now? Sorry.
It's better, thank you.
It's better?
Oh, you can't see it? I'm sorry, Jiri, they can't see it still.
Yes, but it's shared. So. Yes, okay. Okay. Thank you. It's shared now. Good?
Good, Idan?
It's fine? Can you see it, please?
Yes, we can see it. You can continue.
Yeah, I can continue. So again, this is the introductory slide. We'll talk about depression and existential distress in oncological patients. And I'll show you the design of two studies. First is on psilocybin and second on psilocybin versus ketamine in oncological patients. And second is on major depression. For the purpose of our research, we have the Psychedelic Research Foundation, which is oriented to finance our research at our institute. And our credit is based on the tradition, so psychedelic research from 60s, with Stan Grof as one of the most important person in this field, and he used to work in our institute before he moved to United States. Second, we are I think credited by the extensive psychedelic research. Here is the room, which is in true is the EEG Faraday cage, and when our experiments are typically conducted. And here is our 3 Tesla magnetic resonance, and here you can see also our institute, which is quite modern and oriented on the neurobiology and psychiatry in general, not only on the psychedelic research, of course. We published a bunch of papers on ketamine, both in rats and in humans, and also on psilocybin. So these 2 drugs are typically studied in our institute. Here is one study which is of particular interest for the purpose of my talk today, because in this study we tested the oral ketamine, the oral form of ketamine, which is quite important when we want to compare ketamine with psilocybin in humans. So we have experienced this oral ketamine as well. The topic of my talk is the fact that psychedelics in general showed the fast antidepressant effect, and these drugs represent the very promising wave of treatment, and the tool how to cope with the problem that standard antidepressants like Prozac and many others have the delayed onset. So if somebody suffers from depression and we prescribe antidepressants, the problem is that we can expect the clinical onset after several weeks, typically after 4 or 5 weeks, and that's the problem because it prolongs the suffering of people with depression, and we need some alternatives this fast antidepressant effect. The fast antidepressant effect was documented both in ketamine and also in the traditional psychedelics, sharing the serotonergic properties. So in ketamine and psilocybin, dimethyltryptamine and other drugs, there is one common denominator at the neurobiological level, and it is represented by the neuroplasticity. The term neuroplasticity means that the synapses in brain which connect the neurons are growing very fastly. So these drugs induce the growth of synapses within hours, and that's quite promising, because the traditional antidepressants like Prozac and others also induce the same neuroplastic effect, but within weeks, not within hours. So that's the point. And this fact enables us to expect the very fast clinical effect. The clinical effect, the fast antidepressant clinical effect, was firstly documented in ketamine in 2000, and these fascinating findings, which was really epoch-breaking in the field of treatment of depression, was rapidly replicated by many studies, as showed at this slide. One of these studies shows is ours, this one, I think. Our information or the fast antidepressant effect is less documented in traditional psychedelics, specifically in modern studies. In the 60s, of course, the LSD was tested in depression with some results, but the methodology from studies from that time is not applicable for the modern standards. So now we have only one study with psilocybin performed at Imperial College by Robin Carter-Harris. And this open study documents also the very rapid antidepressant effect in psilocybin, but this effect is not still replicated, and it's waiting for replication, which is absolutely essential. When we compare the data, or these two slides, we cannot say nothing about or anything about the intensity of the antidepressant effect, because these two drugs, psilocybin and ketamine, were not yet tested together head to head, were not yet compared. But what we can see here is the fact that the antidepressant effect of ketamine lasts only days, typically 4 to 7, so up to 1 week. We can expect the clinical effect. But in case of the Robin study, the psilocybin produced the effect which lasted for weeks up to 3 months. So it's possible to expect, or it's hypothesized, that the antidepressant effect of the traditional psychedelics like psilocybin will last longer than in ketamine. But it's still open question to be tested. Our previous contribution to this field is documented by several studies. For example, we found that ketamine produced the same neurobiological changes in brain detected by EEG as the same changes as standard antidepressants do within weeks. So ketamine ketamine performs it within minutes or hours. So that's quite important. The second contribution is this study, in which we found that the antidepressant effect of ketamine relates to the intensity of the psychomimetic effect during the intoxication. In other words, the stronger psychomimetic or psychedelic effect of ketamine during the ketamine infusion, the better treatment outcome. It's quite important finding because it says that the quality of intoxication and the character of intoxication really matters. Maybe the intoxication reflects the neuroplastic changes. So when people are intoxicated, the phenomena which they enjoyed are related to new synapses which grew in the brain. This finding also indicates that setting that these two principal components of the psychedelic experience are important also for the antidepressant effect. And it also highlights the importance of quality psychotherapy, which is combined with, or which should be combined with the treatment of depression by ketamine and psychedelics in general. There are several studies on psilocybin in treatment-resistant depression, which are now registered or which are now ongoing. I think that the farthest one is the Compass study, which compares 3 doses of psilocybin. Our institute also participates on this study, and we also already enrolled the first patients. But when we look closer at the protocol of Compass study, we can see that this study compares in the parallel regime 3 doses of psilocybin. 25 milligrams, 10 milligrams, so high dose, the middle dose, and very low dose, 1 milligram of psilocybin. The low dose, 1 milligram of psilocybin, is in this study involved as the placebo. 1 milligram of psilocybin in healthy volunteers and depressive patients is very low, producing. And there are two possibilities. First is that 1 milligram does not produce any effect. So in this case, that's the problem, because the study is not effectively blinded, because the patients or the volunteers will be able to recognize that they are on inactive dose of psilocybin, on placebo, or 1 milligram of psilocybin will produce some psychedelic effect. I'm skeptical about this, and in this case, it's active dose and it's not placebo. So in this study, we identified, and others two problems. The first problem is the fact that it's not effectively blinded. So the placebo problem, which is really the big problem in psychedelic research, because people are able to recognize that they are on psychedelics and not on placebo. So the study is not effectively blinded, the first problem. And the second problem is that there is not the active comparator. So the standard antidepressant, or in case of the research question, what's better, ketamine or psilocybin? Ketamine is missing here. So standard antidepressant or ketamine should be there involved, and it's not the case. So we identified several knowledge gaps and unsolved problems to be addressed. The first problem is that we do not know if psilocybin is better than ketamine or vice versa. So there were no head-to-head comparison comparisons on this question. These two drugs should be compared in terms of the intensity of antidepressant effect in the short-term horizon, and also in the long-term horizon in the duration. So is really the duration of antidepressant effect longer in psilocybin than in ketamine? We don't know. We have hypotheses, but without properly designed study, we can say almost anything about this. The second problem is the effective blinding, or the placebo problem, which is the problem of psychedelic research in general. To address these two questions, we brought two solutions. So we designed two clinical controlled trials. Both of them are based on head-to-head comparison of these two very promising candidate drugs. What's important to be able to compare them is to have the same way of administration, the same drug form. So both ketamine and psilocybin we administer in the oral form. We found the correct dose of ketamine, which is possible to induce the effect, which is quite similar to the standard dose of intravenous ketamine, which is used classically in psychiatry from 2000. The second problem is the placebo, and our solution is based on mimicking the effect of both psilocybin and ketamine by the middle dose of midazolam. Midazolam is benzodiazepine, which is typically prescribed for insomnia, so for the sleep drug. It's a sleep drug, and it's insomnia. It works at the dose of 10 milligram. If the dose is slightly lower, we use 5 milligrams of midazolam. The research subjects first can feel something, that something is happening with them. They feel to be slightly dizzy, and this effect lasts for 2 or 3 hours. So that's okay for the purpose of the study. So that's our solution of the second of the placebo problem. So we designed protocols of 2 studies. First of them is psilocybin versus ketamine in treatment-resistant depression. So the standard question, which is addressed by many studies. Now, this study will enroll 60 patients. And what's very important is that this study is already approved by the FDA equivalent in our republic. It's called Zucker. So we have the official approval. So we can start now if the study was financed. So that's the problem and the purpose of my talk, of course. The second study compares psilocybin and ketamine in depression in cancer patients. So the second study addresses the quite important question related to the so-called existential distress, the typical depressive syndrome the cancer patients suffered from. I think that the existential distress or depression in oncological patients or palliative care in general is so important The reason is that we have absolutely no treatment for these patients. Many oncological patients, almost 50%, suffered from depression, but the standard antidepressants are not effective in this indication. That's the problem. Or if they were effective, or if they are effective, the onset is delayed, is almost longer than in it's much more longer than in standard depression. So it's possible to expect that if there was some antidepressant effect, it's possible to expect it after 14 to 16 weeks, according the last meta-analysis. And this period of time is frequently too long for patients typically with advanced stages of cancer. So there are some data from 60s that LSD could be effective in existential distress or depression in cancer patients, but these studies are of poor quality, the methodological quality, and it's not possible to use them today to advocate this treatment. But from the recent time, we have 4 properly designed studies done by Peter Gasser, Griffith, and Ross, published, and which showed and clearly documented the effect of psilocybin, or in case of Peter Gasser studies, of LSD in these indications. These 4 studies brought 3 major findings which are absolutely essential for us. So these key findings are represented by the fact that psilocybin or LSD, in case of the small study by Peter, are effective. So they can effectively ameliorate the depressive symptoms in these patients. The response rate in the oral Griffiths study was up to 80% after single dose. So it's fascinating effect. The second finding is that after 1 or 2 doses of psilocybin, the effect lasts up to 6 months. So the effect is prolonged, and we can talk about the long-term effect of single dose. What's very interesting, and this long-term effect is mediated both probably both by the neurobiological effect on synapses, synaptogenesis, neuroplasticity, and also the psychological effect, of course. So, and the third important finding from this study is that the antidepressant effect, specifically in this indication, is mediated by induction of mystical domain of psychedelic experience. The mystical domain in the modern studies is measured by mystical experience questionnaire MIQ, and the study by Ross showed that probably approximately 50% of anxiolytic and antidepressant effect of psilocybin is mediated by the MEC questionnaire score, or by the mystical domain or mystical dimension induced by the psilocybin. So not the visual hallucinations or illusions, synesthesias, and all these spectacular phenomena are so important for the antidepressant effect, by specifically the mystical domain. So both of these studies which we prepared, one of them is approved by FDA, shared the design. So the primary objective is to measure the rapid antidepressant effect measured by Matters scale. And the second objective, or the secondary objective, is to compare psilocybin and ketamine in the duration. So to measure the duration. In both of these studies, we have psilocybin in the dose of 20 milligrams. We think that this dose is slightly better because it's slightly lower than 25 milligrams in the concurrent COMPASS study. And the 20 milligram of psilocybin is compared with 200 of milligrams of ketamine administered perorally or orally. So 200 milligrams of ketamine has approximately the same, produces approximately the same psychotomimetic or psychedelic effect as 20 milligrams of psilocybin, and the effect is quite comparable with the standard intravenous dose of 0.5 milligrams applied within 30 minutes in the intravenous studies. And these two drugs are compared with midazolam at the dose of 5 milligrams. So that's the way how we cope with the problem of blinding. The next improvement which we brings with this study is the very detailedly described structured brief psychotherapy, which is designed to be quite practical and applicable not only at the psychiatric departments, psychiatric hospitals, but also at the departments of general hospitals and oncological departments, where the patients suffering from the oncological problems are typically treated with their oncological problem and with the concomitant depression as well. So this brief psychotherapy consists of 2 preparatory sessions during which the subjects are prepared for the effect. Their psychological needs are mapped in details, and they are also prepared for some challenging experiences and for the intoxication in general. Second, our protocol consists only of 1 intoxication when psilocybin, ketamine, or midazolam are administered perorally, and the last part of the psychotherapy consists of 3 integrative sessions in which the subjects are instructed to utilize the maximum from the experience which they obtained during the intoxication by psilocybin or ketamine or midazolam in case of placebo. Here is the chart of the study oriented on depression. Here are the inclusion criteria. It's not necessary to go through it in details, but they are clearly defined how the treatment resistant is defined. So we targeted the treatment resistant patients. Here are the inclusion and exclusion criteria for the cancer study. And for the purpose of my talk, that's important that we will involve patients suffering from cancer, different forms, and with comorbid depression defined according to ICD-10 criteria, and the cancer. And we are quite open for the staging of cancer. So we will enroll patients in advanced stages with poor prognosis. Or with patients even with better prognosis, but if there is the comorbid depression present. So these criteria are very practical and are not very strict. So the comorbidity of depression and any oncological problem which is treated in the current period will be involved. But what's I think quite important on the design of our cancer study is the fact that if the patient will not respond at the time point for the main outcome defined or main objective, the primary objective defined as the amelioration of depression after 4 weeks from the initial intoxication, we will offer them the active treatment, even in the case that they were on placebo. So in case that our oncological patients were on placebo and they don't respond at the week 4, we will switch them to the active dose, psilocybin or ketamine. They will be randomized second randomization. And if these patients had been on active treatment on placebo or ketamine and did not respond after 1 month, so we'll switch them to the second active drugs. So if they do not respond during the first month on psilocybin, we'll offer them ketamine and vice versa. So this protocol is designed to ensure that all these severely ill patients suffering from both depression and cancer will have the pretty good chance to profit from the participation of our study. Here is the table from for the cancer study, and I use it only to document that we'll measure not only the mothers, the Montgomery-Åsberg scale for depression, which defines the primary objective, but we also utilized many other scales which had been previously designed for the patients suffering from such life-threatening disorders like cancer. So we utilize the death and dying distress scale, demoralization scale, and many others to map in details the effect of these two psychedelics or drugs with psychedelic properties, and to have the good chance
Hi, Jiri.
to describe it.
This is Deborah speaking from Tel Aviv. Thank you so much. I'm sorry, if we could just wrap it up a little bit because we are on schedule at the moment.
Okay. So, what to do now? So you can support us if it's possible.
Jiri, it's okay. You can just finish up and then we'll carry on with the next speaker. Thank you so much.
Yes, so if you want, you can support us. Thank you. Bye-bye.